Okay, so hopefully you can see this okay. So yeah, real delight to be joining you this afternoon and today, and to speak with you about mindfulness in palliative care. So I realize that this is really going to be quite a shift in tone to a certain extent, given the presentations that we've been privy to so far today. And I guess I've been sitting here with a sense of kind of back to the future a little bit with mindfulness in palliative care, because even though mindfulness has been around for a very, very long time and is a core part of Buddhist practice for well over 2,500 years, mindfulness being synonymous with awareness is really a capacity that we all have to develop. And I think one of the key drivers for me in terms of mindfulness in palliative care is almost to kind of preempt the future in some ways. So mindfulness, as we know, is now being taught in primary schools and secondary schools, in workplace settings, in Harold's Cross, but essentially anywhere people experience stress. Chances are mindfulness is now being introduced and taught as a way to try to manage stress. And so with that in mind, I was very keen to try to preempt the future in a certain way, and try to think, well, if more and more people will have some exposure to mindfulness by the time they become seriously and terminally ill and will be receiving palliative care, how might they best be able to harness the mindfulness training that they've had previously, which in many ways is maybe a bit like kind of riding a bike. We never quite lose the capacity, because it's an inherent capacity of awareness. But how might we best bring it to the experience of serious and life-threatening illness? And so that was a real driver behind my own research, and so it'll be a great privilege to share some of that with you today. So, as well as sharing with you some reports from my own research and from some courses that we ran here at the hospice, I'd also like to offer an additional rationale for offering mindfulness as part of, we've heard a lot about how palliative care is developing, and just now in Jenny's talk, the talk about technology, and in some ways, it might be helpful to, I hope the link isn't too kind of opaque, but to see mindfulness actually as a kind of an inner technology that we might be able to cultivate and bring to the experience, both as staff. And I think this is again one of the potentials for mindfulness in palliative care, and one of the potential kind of evolutions that could possibly take place in the future is in seeing mindfulness as a kind of a shared practice and a kind of a shared dialogue that we can have with patients who are really suffering. I guess, well, not all of our patients may be suffering, but it might be a way to meet the experience of our patients in suffering that, interestingly, actually doesn't require dialogue. It doesn't require anything to be really said or done, but actually is a way of meeting perhaps our patients who are at their limits, but also crucially for ourselves as healthcare professionals. And Michael Carney talks about recognizing when we're at our limit in the healthcare encounter. And so if we can recognize when we're at our limit in the caregiving encounter, we then have a choice in terms of what to do next. And I guess Michael, and I think I would share this view, advocates the view that maybe that might be a pivotal moment to step back or to step inward, as opposed to continuing to maybe look outward or to do more, which may end up actually being counterproductive. So many of you will already be familiar with mindfulness, but here's a definition that I think is slightly more nuanced, and I'd like to read this for you, if I may. So mindfulness is best considered an inherent human capacity, akin to language acquisition, a capacity that enables people to focus on what they experience in the moment, inside themselves, as well as in their environment, with an attitude of openness, curiosity, and care. So these attitudinal qualities of mindfulness, of openness, of curiosity, and care, these aren't passive qualities. These are actively cultivated within the practice of mindfulness. And I think this is quite key to understanding mindfulness, not as something passive or not as something, I guess it distinguishes mindfulness from, let's say, other mind-body approaches that might have a more kind of a relaxation element to them, or a relaxation goal, which in and of themselves are absolutely fine and have their place. But in terms of mindfulness, we're not really talking about a warm fuzzy here. We're talking about meeting our experience in the moment as it is, and meeting ourselves in the moment as we are, which, when you think about it, might be very different to how we ordinarily are with our experience, particularly if our experience is quite challenging, because often the drive is to change things, to make things better, and to fix things. And of course, as we know in palliative care, that's just not always a possibility that's available to us. So this is really speaking to a kind of an inner technology. How can we cultivate this capacity in an active way within the experience of serious and life-threatening illness? So as we know, mindfulness is not new, and what's so interesting about the research that's being undertaken now in terms of fMRI studies and EEG studies is that it's really giving us some really great insights in terms of what is possible as we cultivate mindfulness in a particular way. And again, what's so fascinating is even after just 8 weeks of a regular form of mindfulness practice, it can lead to structural brain changes, which is really just fascinating. This is a picture of Mingyur Rinpoche, who has well documented over 60,000 hours of meditation practice under his belt, and in terms of the kind of EEG changes that have been seen in experienced meditators like Mingyur Rinpoche, essentially the kind of what's been documented, the data that's been seen is kind of off the charts in terms of these very high frequency gamma oscillations in the brain. So it's a fascinating area in and of itself of research. So it was really John Kabat-Zinn's particular genius, I think, to foresee the potential for mindfulness-based approaches and to translate them to a certain extent to a Western healthcare context. And so John was really working with people at the University of Massachusetts Medical Center, where he set up the Mindfulness Stress Reduction Center at UMass. And I think, again, it was part of John's vision was that research would be embedded into these very early programs that he was running back in the late 70s, and really set the ground for the potential for mindfulness-based approaches for people who really to a certain extent, had fallen through the cracks of the medical system, were very much suffering, but for whom the medical model had also reached its limit. And so John was really keen to support patients to support themselves as best they can in the experience of, in his particular context, in living with chronic illness and in particular chronic pain conditions. So as you can see, you know, when John started back in the late 70s, there was almost no papers being written, to a situation now where, particularly over the last 20 years, again, really anywhere that people are experiencing stress, chances are that people are applying and adapting mindfulness to that particular area. And so palliative care being no exception, and I'll talk a little bit about that later on. So given all this research, what do we know? Well, you know, in terms of MBCT, or mindfulness-based cognitive therapy, this was quite an important shift in the field, because in 2009, NICE recommended MBCT for recurrent depression, and so it's now available in the NHS and has been rolled out across the NHS, because we now know that MBCT for depression is as effective as medication for those at risk of recurrent depression. So these are people for whom have had 3 or more episodes of major depressive disorder. So that's quite incredible that a mindfulness-based cognitive therapy, this third wave therapy, might have you know, similar effectiveness as medication use for recurrent depression. So that was really key in terms of establishing MBCT. And you know, just to say, there has been a lot of caution around seeing mindfulness as a panacea. You know, we hear a lot about mindfulness in the media and really everywhere. And I think you know, what's been quite important is that I think, as Professor Davies was speaking about earlier, it's really meant that we've had to up our game in terms of the mindfulness research that's carried out. So, you know, a key criticism for the early mindfulness studies was that they didn't include active controls or dismantling designs in terms of looking at the effectiveness of, as this review looked at, looking at active controls or evidence-based or pre-existing evidence-based treatments. So this recent meta-review is quite important, just at summarizing where the field is at. So absolutely some caution around seeing mindfulness as a panacea. And of course, we're hearing about mindfulness everywhere now. But I think also important to recognize that it's meant that the field has had to really up its game in terms of what we're comparing mindfulness-based interventions with. So what about in palliative care then? Well, just to say, there has been really few studies and quite weak evidence for the most part in terms of patient reported outcomes, and where the evidence has been there, the exposure to mindfulness has really been quite limited. And again, this is a problem, this is a difficulty, because it then becomes difficult to compare the kind of active component, if you like, the mechanisms of mindfulness with other treatments, like, for example, active relaxation. So this was something that I particularly was keen to look at, and so the participants and patients that were recruited into my own study, I was really keen that they have at least 6 months experience of mindfulness under their belt, of having developed a regular practice over at least 6 months, so that they really understood what mindfulness was. And for example, they were able to distinguish it from, say, a form of active relaxation. In terms of the evidence that is out there, I'd just like to name 2 studies that are that are, I think, an exception to it. One is Ursula Bates's study. Ursula, as we know, who was based in Our Lady's Hospice for many years, in her own doctorate study, really made an interesting finding in terms of applying mindfulness in palliative care, and that is that she discovered that over the course of time, as people engaged in mindfulness practice, they shifted from having a narrative of illness, a narrative, so the story of illness that was so predominant in their minds in the early sessions, really kind of receded over time, to allow the patient to be much more present moment oriented. So that's quite important, from a psychological perspective, because so often, the kind of stories we tell ourselves, and particularly for our patients, the kind of illness narrative, the story of illness that they've been through, can really so predominate their experience, that they're not really available to experience, what time is available to them. So this shift from being having a narrative, an illness narrative, to one of being much more present moment oriented was really important. The second study was a Swedish study, and what was important here is that they include measures of symptom burden, along with other outcome measures. So that was important from a palliative care perspective, because it was the first time that had been done. I guess the weakness there, again, was that the mindfulness exposure element was quite limited. So, we've had a look at some of the evidence for mindfulness so far, and we've seen the growth of mindfulness-based approaches and interventions, generally speaking, in healthcare. But I wanted to just now change tack slightly, and offer this additional rationale for offering mindfulness in palliative care, and it's really a rationale that's based around the patient's experience of illness. So this comes from the work of Eric Cassell, who has written a lot about suffering in palliative care, and Michael Carney had developed this model on the basis of Eric Cassell's writing. And it just reminds us really that in terms of the patient's own internal experiencing of their illness, it's comprised of at least these two parts. Those aspects of their illness, such as pain or other symptoms, that are responsive to interventions of the medical model, and also, crucially, that their experience of illness is also made up of those aspects that may be unresponsive to the medical model. So I think just helpful to kind of bear in mind, in terms of the patient's inner experience, that it's made up of these two aspects, and that in terms of suffering, the medical model may be quite limited in responding to this. As we know, Dame Cecily Saunders did much to articulate the phenomenon of total pain, and in a way to draw our attention to the different aspects that might be feeding into our patient's experience of total pain. And I'd like to use this as a model to present some of my results in a few moments. As we know, in terms of the competencies that we share in terms of responding to our patients' experience of suffering, we all bring something to the table and to our patients in terms of offering multidisciplinary palliative care. But I think maybe also helpful to bear in mind, again, what Michael Carney has drawn our attention to, that there are occasions when we're at our limit in the caregiving encounter. And again, this is one of the rationales, I think, for offering mindfulness in palliative care, that there will be some instances where we may not be able to meet our patients in suffering. So this rationale for mindfulness is also one that Michael offered in terms of the containing function of palliative care, and this really comes from this idea comes from the work of Wilfred Bion, who was a British psychoanalyst and did much really to help to try to articulate his sense of infant development, and particularly the development of an infant's thinking. But I think what's so helpful about this metaphor for palliative care is, as we'll see, just to use the metaphor as palliative care as playing a containing function, and within that I would like to offer mindfulness as playing a containing function at an intrapsychic level. So I might just read this because I think it might helpfully orientate us to how we might see palliative care in general. So Bion gives the example of the infant fearing it is dying, which in turn arouses the fear that it is dying in the mother, and concludes, a well-balanced mother can accept these feelings and respond therapeutically. That is, in a manner that makes the infant feel it is receiving its frightened personality back again, but in a form that it can tolerate. And I'd like to offer this additional quote, and this comes from, the context of this quote is a conversation that Cecily Saunders was having with two psychiatrists. And it came in the context of one psychiatrist wondering about how the hospice could offer a place of safety for patients when dying is one of the most unsafe things there is. And so it was at this point in the conversation that the other psychiatrist made a distinction between security and safety. So again, I'd like to read this for you, if I may. A child separated from her mother may be quite safe, but feels very insecure. Whereas a child in her mother's arms during an air raid may be very unsafe indeed, but she feels quite secure. And so Dame Cecily went on to say, we have to give all patients that feeling of security in which they can begin, when they are ready, to face unsafety. So again, in terms of what we're offering in palliative care, in terms of this sense of offering a containing function to our patients, I think just again a very helpful metaphor. And of course that there may be some patients and some instances in which our patients may never be ready to face the unsafety of their dying, and that's part of the I guess that nonetheless impacts on our impetus to still serve that containing function for our patients. Just in terms of what I think are different levels of containment that are happening within palliative care, as we know from a kind of a sociocultural perspective, palliative care are seen as experts and really kind of play this holding function for society at large to a certain extent as experts and placeholders in end-of-life care. And in terms of our hospice environments, this really starts with the environment itself, that hospice settings, once people walk into a hospice environment, immediately there's a sense that there's something different here. There's something different about this environment. And if any of you can remember back to having Rian or Cashel living on our ward here in St. Gabriel's ward in Harold's Cross, that played a very immediate kind of, oh, there's something very different about this hospice environment. Obviously, also at an interpersonal level, as we've seen in terms of the different competencies that we bring, the MDT shares a role in containment of our patients. And of course, all of this rests on the physical, on excellent symptom management. But I'd like to just kind of pause for a little bit on the intrapersonal. So my role as a psychologist in palliative care, I'm very keenly interested in how our patients navigate the experience of a serious illness and end of life. And so it's I guess my particular interest in terms of what mindfulness might have to offer is at this level of the intrapersonal, supporting our patients' own ability to contain their own experience intrapsychically. So we know, of course, that mindfulness was first offered within in a Buddhist context and is offered within a Buddhist context, and so that might speak to the more transpersonal or spiritual aspects, which obviously also our chaplaincy colleagues really speak to. But I'm really kind of more interested just purely on a kind of an intrapsychic, intrapersonal level. Though that's not to say that mindfulness might not act as a kind of a doorway into the transpersonal or into the spiritual, which actually we'll see in a few moments that it can have that effect. So I'd like to move on and offer just some brief quotes from patients who were recruited. And again, these were patients with a well-established mindfulness practice. And again, the driver was to really try to understand what their experience of using mindfulness was like whilst receiving palliative care. So using Cecily Saunders' model, first of all, at a physical level, this patient said, "I suffer a lot of headaches, so you can figure out you're not sore everywhere. Like the pain is only in your head and only in certain parts of your head." So if you can remember back to the definition that was offered earlier in terms of what mindfulness is. So mindfulness as an approach to experience that encourages a sense of openness and curiosity and care. I think what's really fascinating about this quote is that it kind of speaks to the sense that this patient was able to orient toward their experience in a way that may be very different to how we might ordinarily orient to an experience, for example, of physical pain. To such an extent that this patient was able to kind of distinguish and tease out that actually, oh yeah, there's pain there, but there's different parts to it. So, again, at an intrapsychic level, obviously this doesn't diminish in any way, the need for medication. And I mentioned that because some patients did actually mention that it reduced their medication use. So that was speaking to a kind of a more mindfully informed medication use. And I wondered about that. And I think this quote really speaks to, if our patients are encouraged, to, and again, this isn't going to apply to all patients at all times, but at least for some of our patients that might be open to this way of working with their experience, it might be possible to tease out the experience in such a way that might also offer our patients a sense of more agency and control over what's actually happening. In terms of the psychological, I think this quote was quite interesting. If I can see it, because it's currently blocked. I think it says, "It makes me calm," and I can see things clearer. So yeah, at a psychological level, in terms of stress perception, we know that when we get stressed, stress has a kind of a narrowing function in terms of stress perception. Stress has the effect of narrowing our attentional field down to a kind of a manageable proportion of our experience. And so if our patients can be encouraged to kind of stay open to their experience, to the totality of their experience, maybe there'll be more choices available to them within it. Just in terms of time, I'm going to move on to the social. So again, palliative care, we're tasked with the care not only of the patients, as we know, but also of the family and the wider circle around our patients. And again, this was a really interesting quote from a patient who used to experience very dramatic pain episodes. So again, pain being a feature for this patient. But mindfulness was really able to support him within the experience, so much so that these very dramatic kind of instances of pain, he was much more able to contain them. But what was so interesting was the ripple or resonating effects of how he was using mindfulness in those instances. So he said, so you think of my mindfulness, but actually it's boiled over into other people. So speaking to the ripples and resonating effects of mindfulness from the individual outward. And then just finally, again, just kind of maybe acknowledging how mindfulness might be a doorway to potentially the more spiritual or transpersonal. This quote, I think, very beautifully speaks to this, and came from when this patient was asked if there was anything else that he wanted to say about his use of mindfulness in his illness. And he said this. He said, I have a favorite quote. I think it's William Blake. I think it's very good for people with, well, don't know how long they have, but to see the world in a grain of sand and heaven in a wild flower, hold infinity in the palm of your hand and eternity in an hour. And so he said, well, to me, it means like eternity in an hour. So, you know, I think just a beautiful example of, you know, how this patient was really able to kind of operationalize William Blake's invitation to us to experience, you know, life in this way. And again, because time can sometimes have such a burdensome function on our patients, because, you know, and we also know that the future in terms of suffering plays a key role in Eric Cassell's definition of suffering, because the future can be so full of uncertainty. The possibility that one may be able to experience time in a more fluid, more dynamic way, in this way, as Blake invites us to, you know, I think this was just a lovely example of this in action. So just to finally give some examples from our courses here in the hospice with staff. I'm going to have to move through this quite quickly, but just to say that these are just some quotes from staff. So we ran, these are from just 3 8-week courses that we ran here in-house, and these are quite you know, these are 8-week courses for 2.5 hours each session for 8 weeks, so the satisfaction ratings were quite high. And on the final evening, people were asked to share their reflections, and these were thematically organized into the following reflections, and they're broken down into personal reflections, and also reflections in relation to the work itself, more professional reflections. So firstly, in terms of linking awareness to stress from a kind of a personal basis, this person said, dealing with stressful situations at home, recognizing my own reactiveness, the stress in me that exacerbates the situation. So pointing towards ways in which we can compound our stress, you know, especially gone unchecked if we're not aware, how we can contribute or we can add certain layers to stress. There was also a theme of seeing differently here with our staff. So having become accustomed to tuning into my inner self, I notice when stressed, I stop hearing the other person and my stressful thoughts run riot. By noticing this, I now listen more in times of stress, and as a result, there's less room for the stressful thoughts. So again, just really insightful how just simply bringing awareness to this person's patterns of reactivity, in this case, to stop listening when they were stressed, allowed them to listen more. And so just moving on to this final theme of being. So more reflection on being rather than always doing. Overall, a feeling of greater acceptance, confidence, comfortable with difficult emotions and situations, feel wiser. And so just to give you some quotes finally from a work context, and I think these are particularly illuminating in terms of what might be possible from a staff and patient interaction perspective. This first quote on this theme is, at times of stress in work due to short staffing, competing priorities, managing others, I've been more mindful by being more self-aware, using breathing practice, leading me to handle situations in a calmer, better, and more productive way. So again, very, very, very typical stresses and strains on this person, but able to use the practice in the moment and to do something very simple, just to move attention to the breath, just to be a resource for this person. On the theme of seeing differently, this participant said, very stressful day at work, running behind, felt that patients were draining me empty, felt like I was becoming impatient and losing empathy. I took a 3-minute breathing space, gained perspective, and was able to see through the day with a recharged battery. So again, I guess we can all relate to these kinds of themes, running behind, feeling drained. And yet this person was able to do something very simple, which, really enabled this person to re-engage in a different way. And then just finally, when I was tired recently on duty, I became aware, so again, awareness entering in here, that a patient required me to really listen and be mindful, and I was able to give them this gift. So all examples of really quite maybe simple encounters, but actually through bringing awareness to the situation, they were able to change the experience, not just for themselves, but also crucially for the patient that they were interacting with. So just like to thank you for your attention and to acknowledge the patients and staff here at the hospice, and in particular the work of Dr. Ursula Bates, and also of staff nurse Emma Duff, who co-facilitated the 8-week courses with me, and also to acknowledge Dr. Michael Carney's work on sharing this metaphor of containment, where I first came across it in his writings. So I have some resources for you and some references, but happy just to, in terms of time, to leave it here for now.